Okay, so um, today I guess we're going to talk about neuro. I think this would be one of the predominant chapters that we would speak about in critical care, just because of the fact that like neurological status changes can inform us of things that are going wrong in the body, and I definitely think that this is one of the highly important systems. Um, so we know that a part of the neurological assessment is PERLA. Does anyone remember what that means or like what we're looking for?
Pupils equal reactive round to light, and then A for accommodation.
Yes, right? So our pupils should look the same size, they should move when we put light to them and they should be able to follow the pen, right? So that's one of our really important neurological assessments. Um, There's also, I remember Dr. Habib said there's something called this Monroe-Kelly doctrine, which means that there's a problem in cerebrospinal fluid, volume of fluid, or blood. If any of these decrease or increase, it's going to affect the others. And we also have the Glasgow Coma Scale. Does anybody remember what's good? Like a good number?
Is it like 12, greater than 12?
Technically, yes, 15 is perfect. 15 is where we want them. 8 is they're in a comatose state. That's really scary. And a score of 3 means they're probably going to die. So, goal is at least, in that 15 range, but definitely we don't want it to get to 8 and never to 3. And cranial nerves, right? So just as a quick like summary and everything, right? We have a couple of those eye nerves. So we're gonna do like that's a part of the Perla assessment when we're able to see their eye movements. We're gonna look at olfactory or their smells, right? We're gonna test their ability to shrug their shoulders, to stick out their tongue, to those facial nerves, to puff their cheeks and squint and all that good stuff. So yeah, those are 4 different things that we could do for a neurological assessment. We could look at PERLA, we have the Glasgow Coma Scale, we have the cranial nerve test, and the Monroe-Kelly doctrine, just to let us know, like, hey, if we suspect something's wrong in one of these 3, we should expect there's a problem. Now, LOC, one of the things that we hear are altered level of consciousness. Right? We want to see what's going on. We want to see how they're responding, how conscious, right? If they become unconscious, we know there's something going on, right? So we definitely need to see what's going on in terms of their level of consciousness. Oh, and make sure to put your SFCID number into the chat. Um, but okay, so right, how can we figure out if LOC changes? Well, we have that glaucoma scale, right, and the neurological exam. So we can look at PERLA, right? If their pupils aren't reacting to light, they could be in a comatose state or something else. So we really need to look at that, right? And look at their nerves. We can look at that glaucoma scale, which tells us their eye opening, their verbal response, and their motor response. Okay, that's 3 to 15. 15 is great, 8 is comatose, and we already said 3 means that probably they're brain dead. So any certain or sudden change in levels of conscious needs to be reported immediately, and we need to take care of um, this very quickly. So we know that we have the 2 hemispheres, right? The right and the left. And the right kind of controls the left side, and the left side of the brain controls the right side of the body, okay? Because of this corpus callosum. I don't know how to say that. Um, but we have different lobes of the brain, right? They all communicate and do different things. We know that the cerebellum, we have both excitatory and inhibitory actions that basically coordinate movement. So cerebellum, movement. Brainstem is what controls our vitals. So that's a very, very crucial aspect to the brain. So brainstem, vitals, and cerebellum, movement. Now, how would we assess if someone is alert and oriented? What sorts of questions? How would we know they're like alert and oriented times 4?
Ask them for the date and time. where they're located,
Who they are.
who they are.
Right? They should know who they are, where they are. If they don't know what day of the week it is, I don't know usually what day of the week it is, so definitely don't ask me. But hopefully the year, and like what's going on, that they're in a hospital or something, right? So if they give us those responses, we know they're pretty much alert and oriented. Also, we can do this based on their responses, right? If we go into the room and we ask them a question and they respond appropriately, that could tell us a lot about their level of consciousness. So we could assess verbal response and orientation, right? Like, who is the president? When's the next holiday? Right? Alertness. Are they able to move their eyes? We want to look at their motor responses, their respiratory status. We already said perla, right? If they become comatose, those eyes will not react. They might not be equal, things like that. We want to look at postures, reflexes, and the Glasgow Coma Scale. Now, priority with neurological is because think about all those CNS drugs too, right? Like antidepressants, benzos, anti-Parkinson's drugs, seizure medications, whatever. Any drug that works in the CNS, the adverse effect is CNS effects, which means there's always a possibility for respiratory depression. So what do we want to do? Maintain a patent airway. So that is our priority with all neurological problems, because decrease in neurological status, especially if it's related to the brainstem, can mean reduced respiratory function. As well as then, if airway's good, let's do our ABCs, right? Breathing. If not, then we're going to look at their circulatory status, and we always need an IV. Now, like I said, we already talked about, right? Complications, right? They can have respiratory distress if their level of consciousness is off, pneumonia, all of those things, right? Pressure injuries because they're not able to move, DVTs, and contractures, which are like permanent stiffening of the leg. It could even lead to like foot drop, where the kind of just muscle gives up. So we already said, right? Interventions. 1, airway, then circulation, then fluid and status needs and nutritional needs, skin integrity, right? So frequently turning them, right? Every 2 hours. Clean around the eyes. And make sure we protect the head from injury, especially if it's a seizure, okay? What else can we do, right? We need to maintain a temperature, right? We know that there's something called febrile seizures, right? They can seize if they have a temperature really high. So we must make sure that we control their temperature. Like you said, if the brainstem is altered, they can have vital sign changes, okay? Bowel movement and bladder movement, right? They might be in a comatose state and they might not be able to go anymore. Or they're going so much that, you're going to have to take care of it, right? Because if you leave them in urine or in poop, they can have skin breakdown. So that's really not good, right? So we want to look, are they having abdominal distension, right? Are we hearing like when we auscultate the stomach, we hear everything that we're supposed to hear. Now, how should we assess the stomach? Like, how should we go about it? Where should I put my stethoscope?
Is it the lower left quadrant?
Not the lower left.
That's where we start. All right. We
Lower.
start from the right.
Yes, we start from the right. So
Okay.
we go to the right lower, then the right upper, left lower. So that's how we're going to check if someone has, bowel problems. We're going to want to use that auscultation technique, okay? So for the bowels, we inspect, we auscultate, and then we percuss and then palpate, right? Because we're not going to want to palpate them first if there's something going on. That's going to be very painful. So we're going to want to look and listen first. Sensory and stimulation and communication, right? Sometimes people who are in these comatose states or have altered levels of consciousness, it doesn't mean they're not there. They just might not be able to get out of the state that they're in. So we should keep their normal day patterns. Maybe put on TV shows that they like if they watch it at 6 o'clock. Allow family to talk to them, okay? We want to keep that going. Now, something that we can have as a problem with the neurological status is increase intracranial pressure, right? So that means there's pressure that's building up in the brain, which can be from like cerebrospinal fluid and things like that, okay? Now, does anybody remember the diuretic that we can use for neurological conditions is only one.
Is it the thiazide something?
It's not a thiazide, it's an osmotic diuretic.
Oh, that's true.
Does anyone remember the name? It's mannitol. So mannitol is an osmotic diuretic that is used for neurological conditions. So it's one of those unique diuretics that we use for things like increased intracranial pressure. Why? Because pressure can be due to fluid buildup. So give them this diuretic, helps get rid of some of that fluid and helps reduce some of that pressure. So early signs of increasing intracranial pressure. This includes first sign, confusion, some sort of LOC change, right? Different pupil sizes. Then they might have weakness and a constant headache. But alterations and levels of consciousness is the earliest sign of increasing intracranial pressure. Late signs include projectile vomiting and a headache and Cushing's triad. Does anybody remember the 3 things in Cushing's triad?
I remember it was a wide pulse pressure. So like
Yes.
there's a big difference between the systolic and diastolic.
Yes. So there's hypertension with a wide pulse pressure. What else? We also have bradycardia, and we have irregular respiratory rate or Shine-Stokes breathing, okay? So bradycardia, irregular respiratory rate, and hypertension with a wide pulse pressure. And that projectile vomiting is another indication of a late sign of increased intracranial pressure. Now, if it gets that bad, right, they can go into one of these like posturings like decorticate or decerebrate. Now I would remember, because I would always get confused, but I remember decorticate because it had the O next to the C. So the hands were on their chest, but their feet were I believe the feet were extended. No, sorry, the feet were flexed. The feet were flexed, but the hands were on their chest, like flex on their chest. But when we had decerebrate, I thought E for extended. So the arms are extended, but the feet were flexed. That's how I would try to remember it, like the little O for on. I don't know. That was my way of remembering decorticate versus decerebrate. But yeah, those are different posturings that occur when, there's severe brain injury. Okay, and it gets really bad. So
Well,
early
Alicia,
signs.
one question. So both of them have the feet flexed. It's the same. It's just the upper part that's different, yes?
Exactly, yes. So I think of decorticate since it has an O on. So the hands are on the chest and flex, but there's an E in decerebrate next to the C, I remembered extended arms.
Okay, yes. Thank you.
Yeah, I don't know. That was just my weird mnemonic or whatever, the way I try to remember it. But yeah, so that's exactly what you said. In both of them, the feet are flexed. It's just the hands are flexed in decorticate on the chest, and in decerebrate, the hands are extended at the sides. So just a quick summary, early signs, we're looking at loss of consciousness, right? Changes that in pupil changes. But in late signs of increase intracranial pressure, we're looking at Cushing's triad or bradycardia, irregular respiratory rate, and hypertension with a wide pulse pressure and projectile vomiting. And if it gets so bad, they can get into one of these positionings. So once again, right, we want to figure out what caused the increase in intracranial pressure. Was it a surgery? Was it traumatic brain injury, right? Now we got to do all of our neuro assessments, right? Our pupil checks, our cranial nerve checks, our cerebellar or our motor, like our movement. We have to check that out. We got to look at vital signs, especially if that brain stem is altered, and the Glasgow Coma scale. So we get all of those things out when we look at a patient with a neurological problem. So What's the priority? Respiratory status. After that, right, like keeping the end of the bed elevated, right? We want to look at cardiac status, fluid, yes, but priority, respiratory. And most of the NCLEX questions are priority, right? So if they're coming in with a neurological condition like ICP, I'm looking at respiratory. And complications, right? So they can have a brainstem herniation, which is excessive increase. It can cause an excessive increase in intracranial pressure. And basically the brain tissue presses down on the brainstem and it decreases blood flow and it can lead to brain death. Neurogenic diabetes insipidus. So diabetes insipidus is not a type of diabetes. It's actually an endocrine-like disorder where there's a decreased secretion of antidiuretic hormone. So that means they pee a lot. Okay, so we can have neurogenic diabetes insipidus. It's not regular diabetes. It just means that they have too little of antidiuretic. If they don't have enough antidiuretic, that means they pee a lot. Whereas an SIADH, this is too much antidiuretic hormone. That means they don't pee. And the problem is that they don't get edema from not being able to pee. They get weight gain, but they don't get edema. So that's something very interesting when it comes to SIAD, which I think is syndrome of inappropriate antidiuretic hormone. And we want to have fluid restriction because of the fact that they're gaining weight, but they don't have edema. And they also have electrolyte problems, okay? So we have to watch that out too. And those are complications of increased intracranial pressure. Now, let's just say there's something wrong with that cerebrospinal fluid, right? Does anybody remember like what we might see if there's a cerebrospinal fluid leakage, like an assessment finding? Well, we can have clear fluid draining from the nose, right? So if we have like this fluid that's coming out of the nose and then they're having a salty taste in the mouth, that might be an indication that, hey, they're having a cerebrospinal fluid leakage. Also, if you didn't put your SFC ID number into the chat, please do that. So yeah, I just want you to know for cerebrospinal leakage, think of salty and think of clear nasal fluid draining from the nose. Now, I've been going over seizures all day. So a seizure simply means that they have abnormal electrical activity in the brain. There's a focal seizure, which means it originates in one part of the brain. And there's generalized, which means it occurs all over the brain. Now, seizures can be caused by a lot of things. Hypertension, hypoxemia, fever, right? Like a febrile seizure, central nervous system infections, like a septic infection, right? Toxins, brain tumors, drug and alcohol withdrawal, all of these can cause seizures, okay? And there's different types. So some may shake. We might get an aura, which means that they have like a smell or a taste, something that's giving them a sensory, like a sensory change, like, I smell something funny or I taste something funny. That might let me know, hey, this patient might be having a seizure, okay? So they also might jerk and they might seize and, like they might start convulsing. So that's why we put the a lot of important interventions. So since we're thinking about this with seizures, what is our priority with a seizure patient?
Maintaining a patent airway.
Exactly, yes, because any neurologic disorder, the priority is patent airway. Because some of them might even go unconscious and might be unaware that they're having a seizure. They could choke on their own saliva and things like that. We also want to have, what other things that should we do if they have a seizure? What are some other seizure precautions besides making sure they have a patent airway?
Turn them to the side and time the seizure.
Yeah, look at you all. You know a lot, right? What else should we do?
Remove like restrictive, if they're on restraints, remove the restraint or any tight fitting clothing.
Yes, right, because that would be a respiratory problem if we have tight clothing and they can't breathe. Right, we said mark the time, how long, right? Is there anything else that we should do?
If they're unrestrained, we should take it out.
Hmm. Yeah, right, because that could be a problem. Um, right, and we should also have padded side rails, right? So if in case they move too much, so we don't want them to hit their head or anything like that, and they might need oxygen available, right? If something were to happen.
And we don't
Now,
put anything in their mouth.
yes, that's another one, right? Because that would be a respiratory problem because our goal is to maintain a patent airway. So the main ones, as you said, would be, nothing in the mouth, no restrictive clothing, all of those things, and making sure they have a good airway. Now, we also have medical management. So phenytoin is actually one of those drugs that we could use for a tonic-clonic seizure. All of these drugs pretty much work on either GABA receptors, meaning if they work on GABA, they increase chloride channels, which actually slows down the hyperactivity in muscles and that neuron activity to help relax everything. That's why seizure medications are also CNS depressants because they relax everything. Or some of them work on sodium and calcium channels. So sodium and calcium is really important for those action potentials and for the nerves to do their thing. So they will inhibit sodium and calcium to help slow the seizure activity. Now, phenobarbital is one of those drugs, is a drug of choice for like tonic-clonic seizures, but like barbiturates and benzos, they're highly, they create physical dependence. So these might not be good for people who have a history of addiction, but they're great for children. And carbamazepine and levetrimacine, all of these ones, there are other ones that can be used for generalized seizures. And so is valproic acid. So yeah, patient education, right? They need to take their medications, right? So we can help reduce the ability of seizures to occur. It's not going to happen all the time, but at least make them less frequent, right? They should be careful never to stop their medication because that could in turn cause a seizure, right? Look at manifestations of medication toxicity. Making sure that they avoid alcohol, they wear a medical alert bracelet to alert people, hey, like this is a seizure patient, like people need to know that. The same thing with allergy patients. They also need to have medical alert bracelets because we don't know when something's going to happen and we need to make sure that we know what we do in a situation. And we also should identify seizure triggers, right? Like for epilepsy, right? Things like that, like bright strobing lights might tick them off. So, we should be very careful with what we do. Like that's why a lot of videos now, if you notice on Instagram, will say warning, flash warning, because some people who have epilepsy might get little, might seize if they see it. So, because it's going to stimulate that activity even more. So now we have cerebrovascular disorders, okay? So we're talking about things with stroke. Now, the thing is that with stroke, we're talking about there's some sort of disruption of blood flow to the brain, which is why they have a stroke, right? Ischemic stroke means that we are decreasing blood flow by an obstruction like a clot or infarction, right, of brain tissue, okay? Whereas, wherever is it? A hemorrhagic stroke is where it's caused by bleeding into the brain tissue, which is slightly different. And I just wanted to point that out now. So for manifestations for an ischemic stroke, meaning ischemic means like loss of blood flow. So there's some sort of loss of blood flow by something, right? A decrease in perfusion. A typical characteristic of ischemic stroke would be numbness or weakness of the face, arm, and leg on one side, okay? Mental status change, slurred speech, aphasia or dysarthria, trouble speaking. Those are like those stroke signs that you see on the papers in the hospital. This is like characteristic stroke symptoms, right? Numbness, weakness on one side, slurred speech, maybe even facial drooping, okay? Now, the goal is to prevent it, right? So we want a healthy lifestyle, right? Because smoking can increase like deposits, and that can be a reason for ischemia or lack of perfusion to the brain. Okay, they should have physical activity. having a good weight, and following a healthy diet. Those are things that we tell all of our patients, but especially for someone who might be at risk for stroke, right? Because all of these things that we're seeing here can cause strokes, right? Like AFib, diabetes, hypertension, migraines, obesity, smoking. We need to control all of these things, okay? Now, other things that we can do is we can have medical management, or we can give oh man, I forgot the name, the TPAs. I can't, is it Altiplase? Altiphase? I think that's it. I can't, it's not like coming to my head right now. I don't know why. But so we have TPAs, right? We can give them in an ischemic stroke. You know why? Because there's a potential that it can be caused by a clot, and TPAs are clot busters. Now we have anticoagulants, antiplatelets, and TPAs. TPAs can actually break an existing clot. Anticoagulants and platelets don't do that. Anticoagulants especially only prevent new clots from forming. They don't get rid of old. So TPAs can be used for ischemic, but never for hemorrhagic, because that's not the cause. So it would not be used for that. Okay. We also cannot give it to a patient who's hypertensive because they have more of an increased risk for bleeding. Okay. So we can't give TPAs if they're hypertensive. Okay. It's not given orally. And what is this? It's a neuro issue, right? It's a stroke. It's affecting the brain. So we need vital signs and neurological assessments. Okay. So the thing is, like I said, with these, we don't give the TAs if they have hemorrhage, right, or any of that stuff. If it's a hemorrhagic stroke, no. And we don't give it when they have high blood pressure, okay? So those are the things that we can't do. We also can't have the client receive any sort of heparin or low molecular weight heparin because it would increase the risk of bleeding, and TPAs can do that. So, interventions. If we're having a stroke, right, and it's causing neurological problems, what are some of our interventions? Well, we always have to be mindful of respiratory, right, because it's neurological, but we need to do neuro assessments, PERLA, Glasgow, all of that stuff. Right? Are they alert and oriented? LOC and mental status changes are the first thing we're going to want to check, because that can indicate that this stroke is getting worse or something happened, okay? They should be able to move, right? But a stroke might cause, temporarily immobility. So we have to watch that. And once, they're recovering and the doctor orders it, we need to get them moving, right? Because we have to prevent a DVT and more clots, because that's what was the cause of potentially this stroke, was a clot, right? And prevent skin breakdown, because they're going to be on bed rest until they're able. So we need to change positions every 2 hours, right? They're going to need to go to a speech pathologist and speech language pathologist for their speech and swallow evaluation, because they just had a stroke, right? And we're not going to give them anything until we know that they can take something, because then they can aspirate and we can have another problem, right? We're going to look at their sensations, their nutritional status, right? If they're cleared to eat, we could do a puree diet to start, because it's thick and it'll be easy to swallow. We already said skin integrity, bowel assessment and function, because remember, they might not be getting out of bed for a while, so that's not going to be good, and that can cause, they might go a lot in the bathroom, and that could also cause skin breakdown, okay? And once they get going, we really want them to promote independence and get them to do what they would normally do. Now we have a transient ischemic attack, or TIA, which is a neurological deficit resulting from a temporary impairment of blood flow. The other one wasn't temporary in the sense that this could be fixed, and if not, it'll go into an ischemic stroke. You see, this is like, hey, I'm letting you know now, you can take care of me before it turns into a stroke. Okay, so there's something called the NIHSS assessment tool. That's something that we can use to assess if they're having a stroke, right? We already talked about the signs and symptoms that alert us if they're having a stroke. Right, we can give them anticoagulants, remember, because ischemic can be caused by strokes. Statins, why? Because cholesterol deposits could be the reason why they had the stroke, or lack of perfusion to the brain. or platelet inhibiting medications like aspirin, right? To help prevent a clot from starting or prevent cholesterol from depositing and prevent a stroke, okay? So, we can give them thrombolytic therapy, right? So we can give them antiplatelets and things like that, but bleeding, precautions. All these medications that we're talking about have the risk for bleeding, but if we suspect that they're having a trans-ischemic attack, we must give these thrombolytic therapies within 3 hours, right? We're talking about something that can get rid of thrombosis, lytic, right? Get rid of it. So there's a risk for bleeding, so we need to start thrombolytic therapy within 3 hours, or they could have a stroke, and it could lead to decrease in overall improvement. But priority, maintain airway and ventilation for all of these, okay? Because so the goals, right, for ischemic stroke is to have that airway, right, to give them a TPA to break up that clot, but if we have any sorts of signs and indications before the stroke even occurs, we would want to give them a thrombolytic agent within 3 hours of, once we get that information. If we get that information and we don't give it within 3 hours, they are likely to have an ischemic stroke, and our priority becomes maintaining airway. Now, we also can have a hemorrhagic stroke. Hemorrhage, bleeding. So there's some sort of bleeding in the brain tissue. Okay, so it could be spontaneous, maybe an aneurysm, maybe, there's a bunch of different things that can cause it, right? A vessel pops, whatever. But this can cause increased intracranial pressure, which means we got to look at our LOC changes, our pupil changes, and then we also have to monitor for late changes that can let us know that Cushing's triad or that projectile vomiting. Now, we said no TPAs for hemorrhagic, right? Because it's just going to only increase the bleeding. And hemorrhagic stroke can cause hypertension, right? So TPAs are contraindicated in high blood pressure, so that's a no-no. But manifestations for hemorrhagic are a severe headache, early and sudden LOC changes, and vomiting. Those are our 3 things, okay? But ischemic is going to be more of that numbness and loss of sensation in one side of the arm, difficulty with speech, and facial drooping, where this is going to be a severe headache and early LOC changes, okay? Now, how can we see if they're having a hemorrhagic stroke? Well, we're going to take them to a CT scan, right, and see what's going on. We can also give them a lumbar puncture if the CT scan is negative, and if the ICP isn't elevated, because we don't want to do anything to increase the intracranial pressure, right? There's so much going on in there. We don't want to move them that much. We don't want to do anything that can further exacerbate their symptoms, especially because hemorrhagic can cause increased ICP. But always the priority is airway, ventilation, then oxygenation, and then circulatory and everything else, okay? So we need to treat everything, right? We need to treat the high blood pressure. Remember, high blood pressure can lead to seizures, so we got to have seizure precautions. Increase intracranial pressure. We have to watch out for signs and symptoms of this, okay? And we want to try to stop the bleeding that's caused by the hemorrhagic stroke. So, like always, neurological assessment, watching out for ventilation, looking for altered LOC, right? Because we said a manifestation of hemorrhagic stroke is changes in levels of consciousness, right? As well as severe headaches and vomiting. So we got to watch out for that. They might have sluggish pupillary reaction, and they could have speech difficulties and things like that. But like I said, the headache, the LOC changes in the vomiting are letting us know, hey, they might be having a hemorrhagic stroke. Interventions, right? Get perfusion. The problem is that they're bleeding out. So we need to stop the bleeding, and we need to get perfusion back to the brain, right? Because the brain can only handle so much lack of perfusion, okay? So we need to have the head of the bed just steady at 30 degrees, because there's that increased intracranial pressure. So we have to watch out for that. Watch out for the blood pressure, okay? Stool softeners and laxative to help going to the bathroom, because if they try to strain themselves or they're slightly constipated, that can even increase intracranial pressure, right? In a non-stimulating, non-stressful environment. So dim lights, things like that. Relieve anxiety, right? Because they might feel really stressed out and they might, with those LOC changes, they might get really anxious. So we want to calm them down, right? And monitor for those potential symptoms, right? Vasospasms, seizures, right? Rebleeding, anything, right? And I remember this is the chart that we had in our textbook, and it was just a summary, like main presenting symptoms for ischemic. Like I said, it's caused by a clot. It's lack of perfusion, right? It's not complete cutoff of perfusion. It's just a lack so bad that it's causing a stroke, right? Numbness, weakness of the face, arm and leg on one side, and difficulty speaking, right? We need to get if it's a trans-ischemic or the before warning signs, like an attack, we need to get those TPAs within 3 hours, right? But if it's a hemorrhagic, it's a really bad headache and LOC changes and potential seizures, okay? And this one causes more disability compared to ischemic. Now, also just for differences, right? Left and right side can cause different things. Remember, I said the right side of the brain controls the left side of the body, but the left side of the brain controls the right side of the body. So if we have a left hemisphere stroke, we're looking at things going on the right side of the body. So there could be weakness and paralysis on the right side, visual deficit of the right side, speech problems, and altered intellectual ability and cautious behavior. But if it's a right-sided stroke, it's going to affect the left side. So you already know left-sided paralysis or left-sided visual deficit, right? They could be more distracted and more impulsive behavior. Whereas with the left side, the left hemorrhagic stroke, it's more cautious behavior. Okay. So the last few things that we have is meningitis. Does anybody remember what meningitis is?
Fluid in the brain, inflammation in the brain, in the cerebral spinal fluid.
Yes, so there's an inflammation in those meninges of the brain that protect and cover the brain and the spinal cord. So yes, there's inflammation. It can be bacterial cause or viral cause, but mainly bacterial, right? So manifestations, we're thinking about an infection, an inflammatory response in the brain. Anything that ends in itis means inflammation. So if I hear inflammation, right, potential fever, right, changes in LOC, because this is neurological. What are other signs that are really characteristic to meningitis? Well, we have neck stiffness or neutral rigidity. That's really indicative of meningitis if they have a stiff neck. Yes, because fever, also one, but LOC changes in everything, right? If every neurological issue pretty much causes changes in LOC, we need characteristic differences. And one of them is the neutral rigidity or a stiff neck. We could also have positive Koenig sign, which basically means that when the patient is lying with their thigh, like your thighs are on your stomach, right? You can't completely extend the leg. If that's what happens and you can't extend it, that means the sign is positive and they would have meningitis. Another sign is a positive Brzezinski sign, which means that when the neck is flexed, so like coming close to your chest, and your knees are flexed, basically what happens is that you can't really move from that position. The lower extremity of one side becomes like passively flexed, and a similar movement is seen in the opposite, but it's kind of like this person is there, they're in the flexion of the knees, and like the hips kind of move. So if that sign's positive, then we also have a key indicator for meningitis. Also photophobia, which is extreme sensitivity to light, and they can also have seizures, right? It's a neurological problem, so we always have to watch out for the risk of seizures. So yeah, once again, Koenig sign, right? What's going to happen? Thighs flex to the abdomen, and the leg can't be extended. For a Brzezinski sign, the flexion of the knees is going to cause the neck to also flex, and that's going to be a positive sign. And they could also have photophobia or extreme sensitivity to light and neutral rigidity. So that's going to let us know, hey, they might be having meningitis. So for these things, medical management, right, we have the meningococcal vaccine that we can give to 11 and 12-year-olds and a booster at 16. So that's a way to prevent it, right? IV antibiotics like cephalosporins, like citrazone, ceftazeximine. Now, all of those are cousins to penicillin. So what you need to consider is, hey, if my patient has an allergy to cephalosporins, they might have an allergy to penicillins or vice versa. So watch out for allergies. Dexamethasone to reduce inflammation. Remember, this is an inflammatory process, okay? And they can be at risk for seizures, dehydration, and shock. So we have to watch out for all of that. Because remember, when someone has a fever, right, they're always at risk for dehydration and shock. So we have to be really careful with that. Nursing management, it's an infection. So infection precautions until the antibiotic is started. Right? Because we have to be very careful. Until this antibiotic is started, they're very, very infectious, okay? Pain management. Lower the temperature. Keep them hydrated. Anytime someone has a fever, we need to hydrate them. Always assess that neurological status and vital signs, that blood pressure, and things like that. And seizure precautions if that were to occur. And remember, it could also be transmitted through droplets or blood. That's why it's so scary, and we need to get them to have antibiotics, and it needs to be in their system for 24 hours before, we could really start doing things to these patients because they are really, really infectious at that point. So another thing that we have is multiple sclerosis, which is an immune-mediated demyelinating disease of the CNS. That means that there's destruction of myelin, right? And it's that fatty protein material that surrounds those nerve fibers in the brain and the spinal cord. And this basically means that we're going to have impaired transmission of nerve impulses. So multiple sclerosis impairs nerve impulses, usually between 20 to 40 years old. We can use an MRI to look for sclerotic plaques on the brain and spinal cord. If a patient is undergoing an MRI, does anybody remember what sorts of teaching we need to do?
For an MRI, if they have any metals in their body?
Yes, no metals, right? No hearing aids, no credit cards, nothing like that on them. No patches because that can burn them, like transdermal patches. And if they're claustrophobic, that would be a contraindication. Also assessing for iodine allergies because they use contrast in an MRI. So if they have an allergy to iodine or shellfish, that could be a problem. So we're looking at an MRI to see if they have any sort of sclerotic plaques. But manifestations, right? They're basically they're like relapsing, right? On and off exacerbations of MS, which have fatigue, weakness, numbness, difficulty in coordination, pain, loss of balance, and it's really debilitating, okay? So there's really no cure, and the hope is just to reduce symptoms like something with Avonex, or interferon, which is an IM injection, and managing like their muscle spasms, their fatigue, their visual disturbances, and helping them go to the bathroom because they can become really slow and really weak, and it could be hard to move. So our goal is to use a collaborative approach, right? Like get other services involved. Make sure we promote physical mobility, right, to help reduce some of that weakness. Help with that bowel and bladder continence, make them go to the bathroom. Promote speech and swallowing mechanisms because that might become weak too. So we might need to keep up with a speech language pathologist. They said they might have, lack of really ability to focus. So we need to improve their cognitive function. Okay. And home maintenance. We need to have a safe home and a home that minimizes stress. Okay. The next thing that we have is myasthenia gravis, which is an autoimmune disease that affects the myoneural junction, which basically means that antibodies are fighting against ourselves because it's autoimmune at that the muscular neurojunction, which also impairs impulses, okay? but they're just a little different MS and myasthenia gravis, okay? Because this one caused diplopia and ptosis, which are, I think, can someone remind me? I think they're problems with the eyes. I think it's like they can't move them and they might have double vision. Is that what that is?
Don't remember.
Okay, well, if anyone does, or if anyone's able to search that up, just to make sure, because I don't want to say the wrong thing, but I think diplopia, I know is double vision, and I think ptosis means like a lazy eye or something. I'm not too sure. That if someone can find that out for me. But yeah, they could also have trouble breathing and swallowing and voice impairment, right? So if they have trouble breathing, our priority here is airway, right? Breathing. We need to make sure that they're able to get adequate airway and oxygen, okay? So basically some things that we can do to diagnose myasthenia gravis, because remember, it works on the cholinergic receptors. So we use cholinergic-like drugs. And remember, edophonium, we give that to them. And what happens when we give this edophonium, right? They'll get symptoms quickly and then they'll resolve. If the symptoms come and they go after taking this medication, that's diagnostic for myasthenia gravis, okay? And then once we figure out that using edrophonium, we start giving them something that ends in stigmine. So pyridostigmine bromide is a drug of choice, and it's a cholinergic drug. We can also use corticosteroids to suppress the immune system. And yeah, and thank you for that. Yes, so ptosis means drooping eyelid, and its diplopia is double vision. Okay, I just wanted to make sure because I was like, I don't know, I couldn't figure out that one. But yeah, there's also a myasthenic crisis, which means that basically really bad muscle weakness, more than multiple sclerosis, and it can even cause respiratory weakness. So I want you to remember that myasthenia gravis works with the muscles, but can also affect respiratory, whereas multiple sclerosis can affect respiratory, but it's more or less like weakness and fatigue and things like that. And the difference between these two is that myasthenia gravis is autoimmune and multiple sclerosis is not. So management, right? Airway, priority airway, right? Making sure we're looking at the breathing, minimize aspiration, because both multiple sclerosis and myasthenia gravis have the issue of swallowing impairment. So we need to make sure they're followed up with a speech language pathologist, okay? And they could even have impaired vision, because what do we say? Diplopia and ptosis. So we're going to think for this one, which is different, right? Because we didn't have diplopia or ptosis when we were talking about our signs and symptoms for multiple sclerosis. So I just wanted to help understand the difference. And yeah, so there's another one called Guillain-Barré syndrome. Now, this is also autoimmune, and it attacks those nerve myelin, the peripheral nerve myelin, and it causes demyelination, which leads to respiratory failure and autonomic system dysfunction, okay? So they'll have weakness. They need respiratory assistance, and this is an ascending order, meaning it starts with the legs and it comes all the way up to the respiratory tract, okay? So other things we have is parasynesthesia, right? Hypertension, hypotension, the blood pressure is labile, tachycardia, bradycardia. Remember, it affects that autonomic nervous system. Autonomic means parasympathetic and sympathetic. So it's playing with those things, which means that there's a dysfunction. They might have respiratory problems, or they might have too much of a heart rate, low heart rate, things like that. Priority, respiratory. Respiratory, 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 okay? So like myasthenia gravis with Guillain-Barré syndrome, it is respiratory and it's an ascending thing, right? So priority one, improve respiratory function, right? They also have weakness, so they might not be able to move as much. So we want to increase mobility to prevent a DVT, right? Because if they get a DVT, that's a problem, right? And then we're going to have to be really, really careful with these patients, you know, and things like that. So, does anybody remember any sorts of interventions to help prevent a DVT?
Pressure stockings.
Oh yeah, compression stockings. Ambulate, walk.
Mm-hmm. Yes. So walking, right? Because we just said immobility can cause a DVT. So walking, right? Compression stockings, things like that, get them moving. If they have a DVT, we're not going to really want them to move as much because that can actually move the clot, but we prefer them to elevate their legs and things like that. We want to improve nutritional status for these patients. Remember, they have weakness, and some of that weakness could be swallowing and things. So we have to be careful, okay? They might have fear and anxiety because of this. So we just have to be really, really careful and monitor those vital signs, right? Because they have that labile blood pressure and those cardiac abnormalities. Now, the last thing that we have is Alzheimer's disease, which is a non-reversible type of dementia, right? So it's type of dementia. So when we hear dementia, we're kind of thinking about memory, right? So there's problems with memory, problems with judgment, and even changes in personality. So there's mild Alzheimer's where there's just some memory lapses, but it's just short-term loss, like, But moderate, it gets a little worse, and the memory loss becomes more noticeable, and they're even forgetting their own history now, forgetting their own personal life. And severe is where they probably don't even remember who they are or what's going on. So medical management are antipsychotics, antidepressants, analytics, donazepam, which breaks down some of that acetylcholine and things like that to help with Alzheimer's, okay? And ginkgo biloba increases memory, but that herb is like contraindicated in so many medications that you have to ask about herbal supplements. But remember, this is a memory loss. We want to assess their cognitive status, their memory, like, see if they're having personality changes, especially from the family. That's going to be very useful to know, like, if they notice any of those signs and symptoms, because they might not remember, Remember, this is safety. They might forget where they are. They might even get scared sometimes, especially as it progresses. They might not know where they are. So this is our geriatric stuff, right? Like keeping good lighting, nothing on the floors, throw rugs, rails, stuff in the toilet, things like that, prevent skin breakdown. They might forget to move and things like that. They should have a schedule to help follow them and keep that cognitive stimulation going, have memory training and things like that. And yeah,